second. All right, good morning, everybody.
Good morning.
Morning.
Who's SB?
That's me, sir. Hi. I have a desktop and a phone.
Got it. Okay. All right. Let's get going. All right. This is a patient who had a TAPVR repair and is postoperative day 5. And this is an A-wire tracing. And I was asked the question as to whether or not I felt that the patient could have their wires pulled. So why don't I ask Dr. Babia, since I know you're here today, what you think the answer to that question is?
You said it's an atrial electrogram, right?
It is an atrial electrogram, and although I did not perform this electrogram, it's my impression that a precordial lead was used to do this.
And I believe it probably is V1, because that's where I see some deflections where I would expect the P wave to be. So if I suppose that the atrial electrogram is shown at V1, we can see that there is a spike before each QRS, and the morphology is awkward, it's negative. So I wonder if, well, actually, I can assume, I suppose this patient is not atrially paced, otherwise I would see it in every other lead. So this is probably a, it's not sinus rhythm, it's some kind of ectopic atrial rhythm that this patient has.
Why do you say that, Sergey?
I guess because I think that if we had a sinus node working here, the morphology of this P wave in the atrial electrogram would be different.
Does an atrial electrogram morphology tell us whether we're in sinus rhythm or not? Is it different in sinus than it is in some non-sinus atrial rhythm?
Well, since you're asking, I mean, I'm used to, I guess, from my little experience, that whenever we do an atrial electrogram, the A waves are actually more prominent, and you kind of see them. They're as big as the QRS, sometimes even bigger.
Well, what is it that determines the size of the atrial electrogram?
How far it is from the electrode?
Well, I think it mostly has to do with the contact of the electrode with the heart, as well as the contact that the wire has with the device recording it. So I don't think that the size of the electrogram really should give you very much information regarding whether it's a sinus atrial depolarization or a non-sinus atrial depolarization. And so I appreciate what you're basically saying is that because this atrial electrogram appears smaller than what you're used to seeing, you are assuming it is not sinus. Am I correctly stating what you were just saying?
Well, yes, retrospectively it doesn't, and morphology too. And then I guess if we were in, well, that's also hard to say. Why don't we see those P waves more easily in the other leads, not on the atrial electrogram? That's another question that I have. If it was sinus and so obvious.
Can anything about the, so are we in an atrial rhythm, you think? An atrial based rhythm?
The PR, it looks pretty much the same, I think. So the PR is the same. And then I see only one kind of atrial spike in that atrial electrogram. So I would say yes, there's like 1-to-1 conduction probably. It's 2 small boxes, the PR, so that's around 80, which is
So so the reason that this was done, I guess, was to see if we were in a junctional rhythm or an atrial based rhythm. So would you take the wires out? That's the question based on this data, this datum.
mhm. Well, something doesn't look right. I don't know what.
Well, I think the first thing I would say is you really can't tell from an atrial electrogram if somebody is in sinus rhythm. You can tell if there is a P wave before every QRS, and if it's an atrial based rhythm. And so I think you're absolutely right that there is an atrial electrogram or deflection prior to every QRS. So that would suggest it's an atrial based rhythm of some sort. I don't actually think you can tell based on the electrogram whether it's sinus or not. If you were in the EP lab and you knew where you put the atrial wire, you could potentially guess whether it's sinus, because if you were in the atrial, if you were in the high right atrium near to the sinus node, then the onset of the electrogram should be right at the start of the P wave. Whereas if you were in the low right atrium, it should not be at the start of the P wave if you were in sinus rhythm. The one clue I think that might help you in saying this is possibly not sinus is the fact that the PR interval, I think it's actually less than 2 boxes. I think it's like 60 milliseconds. And it's such a short PR interval. Although in small infants you can have a short PR interval, it makes me wonder if it's a low right atrial rhythm, closer. In other words, the impulses are rising closer to the area of the AV node, and that's why the A to V interval is shorter than it would normally be. At least that's a possible theory. And what would be the very best way to tell if somebody's in sinus rhythm, do you think?
Besides the EP study?
Other than putting an EP catheter in and doing an EP study, that would be the best way, I guess. But other than, what would be the best non-invasive way in the ICU?
In the ICU, I guess in the controlled session we can to see if it's in sinus.
So the best way is to get a good 12 lead EKG to really get a nice, clear 12 lead. And unfortunately, in this particular case, the 12 lead, I was first shown this and asked if it was okay to take out the wires. But really, the question I think that was probably being asked of me was, is this patient in sinus rhythm? And if they are not in sinus rhythm, do you have enough confidence in the atrial rate that you can pull them out and we're not going to need to be paced? Unfortunately, in this case, the baseline 12 lead EKG had a very wavy baseline, and it was very challenging to see the P waves. My suspicion is that it was not sinus rhythm, but it is an atrial-based rhythm. And is this a common problem following TAPVR repair? Sinus node?
I would assume so, because we are working on the atrium level. So yes.
Do you see? Do you work, to use your terminology, are we working at the atrial level when we do ASD repairs?
When we do ASD repairs, yes, we also do.
Do we have sinus node dysfunction in those patients when we're working at the atrial level, to use your term?
Well, I guess I should say, if we're working on the ASD level, we're more concerned about heart blocks.
Definitely heart blocks a bigger concern in an ASD, though really in 2021, it should be very uncommon that in a closure of a secundum ASD, one gets heart block. It happens, but it should be very unusual. I don't honestly know if this is a common problem. I don't think it is actually, but it isn't. Can you imagine why it might be that a baby who had this type of repair might have some at least transient sinus node dysfunction, or maybe not transient?
Well, I was thinking,
is it TAPVR repair near the sinus node?
no, it's not near the sinus node, but I was thinking that since there is, even if it's like a sutureless repair of the pulmonary veins, you're still touching the kind of the muscle of the left atrium, so you can maybe cause some foci over there, ectopic foci in the atrium to be more kind of sensitive to firing, to becoming a new pacemaker.
But probably this is in the right atrium, although we don't really know that. I think the point I'm trying to make is that this is an extensive atrial surgery, and probably a very large right atriotomy is necessary to visualize everything. As you know, TAPVR repairs in newborns are not usually sutureless type repair. And oftentimes, a very large atriotomy is needed, and certainly a lot of retraction, I'm sure, of the atrium is necessary in order to see everything, in order to make all of those multiple suture lines attaching everything back to the back wall of the left atrium. So my hope is that this is a transient phenomenon related to extensive retraction and pulling, but it may turn out to be a permanent issue. We'll have to see. Time will tell. But the heart rate is certainly fast enough, and the patient was hemodynamically stable enough that it wasn't unreasonable to think it was safe to pull the atrial wires, with the hope that over time the sinus node would recover, or at the very least that this ectopic atrial focus would be adequate for a normal heart rate. Okay. All right, this is an ECG. It's complete heart block. Would you want the PR to be that long?
No, you would want better AV synchrony and would not.
Right. Normally you would want it to mimic what would be seen in a otherwise healthy person with a normal PR interval. So yes, that's a little unusual choice by the programmer of this pacemaker. Does it potentially give you any insights into what the person programming it thought was going on with this rhythm and what they wanted the pacemaker to do?
Maybe the patient is in like second degree, Mobitz 2, where intermittently they don't conduct, and baseline is in first degree. So if there is sometimes a V that's not conducted, they wanted the pacemaker to kick in.
That's exactly right. That's exactly right. Very well stated. So this patient had advanced second degree block, or Mobitz 2 block, and would conduct though a lot of the time. So after open heart surgery, the patient was observed for, I believe, 10 or 12 days, because there was intermittent conduction, but ultimately there were a number of episodes, particularly when he was asleep, where there were multiple non-conductive P waves, and the temporary wire had to be used. And so based on this, a dual chamber pacemaker was placed in this patient, but the pacemaker is programmed in such a manner as to allow him to conduct on his own, with the expectation that if it would not to conduct, he would then pace after two. So in other words, the pacemaker waits 260 milliseconds after a sinus P wave, and if it does not see a ventricular event, it will then pace. Now, if a patient were known to not conduct a lot of the time, you would rather not leave them with such a long PR interval, as we just said. So if we knew this patient was, going back and forth constantly, very frequently, we probably would shorten the AV interval and just basically pace the ventricle all the time. Similarly, if you are pacing the ventricle sometimes and sometimes conducting, some patients do not like that sensation of the ventricle depolarization changing almost beat to beat. And I've had patients like that in whom, even though they have second degree block and conduct a good percentage of the time, they are so uncomfortable by the change in the depolarization of the ventricle that we end up pacing their ventricle 100% of the time by shortening the PR interval so that they do not feel the sensation of it changing. Now, another alternative approach in a patient like this is we could turn on what's called MVP pacing, which is a feature of Medtronic pacemakers. And this is a Medtronic display. So it's a Medtronic pacemaker. So in an MVP pacing, that stands for minimal ventricular pacing. So the way it works is that the patient is programmed AAI with the assumption that it will conduct most of the time. But if it sees more than one non-conducted QRS or P wave, it will then revert to a dual chamber program with a normal PR interval temporarily. It will then look to see if there's conduction, and if there is, after a period of time, it will go back to AAI. And so the theoretical benefit of that is that it will pace the ventricle less. There'll be less pacing. That has major benefit in terms of battery for the pacemaker and longevity of the device, but it is also a major benefit for patients because in general, ventricular pacing is not as good for your ventricular function as is normal conduction. And so the reason that I don't often turn that particular feature on is the same reason as I explained earlier, which is that if the rhythm is, if you're on the edge and the patient is constantly going back and forth, generally speaking, it's my impression that patients do not like that sensation of going back and forth. If you have a patient who very rarely doesn't conduct, but is conducting the majority of the time, then I think MVP pacing is a great technology to be used. So, so this patient does not have third degree heart block, and the reason for the dual chamber pacer was exactly what you said, Grace, which is that there is intermittent high grade second degree AV block. Good. Let's go to the next one. Actually, let's just do this one. Okay, so Dr. Barris, this is a 2-week-old, and I guess my questions are, what do you think the diagnosis is? How would you treat this acutely and chronically? And what is the natural history?
So just taking a look at our rate here, and it looks like it's pretty fast. You know, I feel like the 260 that the machine is giving me is accurate. And I'm kind of trying to figure out what the rhythm is. I feel like I can see I could see possibly P waves that are coming after the QRS complex. Like if you look in lead 1, I'm looking at the third QRS complex, and I feel like I may see a deflection there in the T wave. In terms of diagnosis, you know, just based on, you know, common for this age, ORT would probably be my leading diagnosis.
Mm-hmm.
And especially given the rate as well. And then in terms of how I could treat this, like in the acute phases, we can use adenosine to try to break this. It would be helpful diagnostically as well as therapeutically.
Mm-hmm.
And then in terms of long term,
how much would you give, David?
so we could do 0.1 mg per kg.
If that failed, what would you do?
We can double it to 0.2.
That's right.
And we can use like for more long term, we can use beta blocker like propranolol. And the natural history would be for it to, most patients would resolve in the first year. I think like 66%.
Yeah,
I think
about 2/3 would resolve. If the patient has Wolff-Parkinson, can you tell actually from this if the patient has WPW?
No, I don't think you can, because you would.
And why is that? I agree with you.
Because the WPW is when you're, you know, conducting antegrade through your accessory pathway, so you're seeing the pre-excitation. But since we're in the arrhythmia now, we wouldn't be able to see that because we're just we're not going to see pre-excitation at this point.
Why would we not see pre-excitation? I agree with you, but why?
Because in ORT, we're going to conduct down our regular AV node, and then we're going to conduct retrograde to the accessory pathway.
That's
So-
exactly right. Right. So you won't see pre-excitation because you only see pre-excitation when you're conducting, obviously, antegrade through the accessory pathway, which, of course, we are not in this rhythm. So, yes. So, in terms of treatment, we here at Mount Sinai usually use beta blockers, but there are many other ways this could be treated. We could use pretty much anything. You could use digoxin. You could use amiodarone. In some countries, amiodarone is the first line therapy, actually, because it turns out that amiodarone is actually very inexpensive in much of the world. And the advantage is it's a once daily medication because of the very long half-life. And if you're using it for a short-term therapy, then it's possible that you'll basically rarely incur any complications of the agent. So some people do that. I remember a paper from Ireland, maybe 10 or 15 years ago, saying that almost everybody in Ireland who has SVT is treated with amio, actually, as a first-line agent. You could use sotalol. It's a lot of different age, flecainide even, although I would personally not use that because of the potential for pro-arrhythmia. And I think it's possible that we can say that there may be a retrograde P wave in the T wave. It's hard to say for sure. And I wouldn't put too much into the fact that it's 265 certainly means that the likely diagnosis is ORT or AVNRT. Why is it not? What would the heart rate be if this were atrial flutter, do you think, Dave?
I would say it would be about maybe let's say the atrial rate was 400 or so. So
Yeah.
maybe, and it was blocking 2 to 1, it would be more like 200 or so.
Right, that's right. So if you see a narrow QRS that's closer to 200, usually, not always, but usually that would be more consistent with the diagnosis of neonatal atrial flutter. The fact that the heart rate is 265 would put it more in the category likely of AVNRT or ORT. I think it's ORT. I think if you look carefully, this tracing is a little bit out of focus. It's an old one I had from 2013. But I think you can convince yourself that there may be a little indentation on the T wave that may be consistent with an RP interval that exceeds 70 milliseconds, meaning that it is more consistent with ORT. Okay, and I think actually we had a patient not too long ago who came in ORT and had a little bit of a tachycardiomyopathy, although thankfully resolved very quickly. Okay, I think with that, we are going to stop. Oh, one last question, Dave. How long would you treat this? So you've converted the patient, you've started, let's say, a beta blocker. How long do you have to treat this patient?
So I think that we would dose the patient for the neonatal weight, and then maybe let the patient outgrow the dose, just weight-based.
Well, that's certainly a possibility. The short answer is nobody really knows what the right answer is, but recent work has suggested that, interestingly, electrophysiologists tend to be a little bit more aggressive about stopping arrhythmia therapy in newborns earlier in their first year of life than general cardiologists. And there doesn't appear to be any difference in the recurrence rate when you stop it at, say, 6 or 8 months versus a year. So traditionally, we have usually treated for a year, but a lot of people now, in the absence of recurrence, have been stopping therapy earlier and earlier. So I think probably almost nobody would stop before 6 months of age, but there are an increasing number of doctors who are between 6 and 9 months considering discontinuation of therapy in the setting of no recurrences of tachycardia. It doesn't mean that you can't recur, but it doesn't appear in small studies as if the likelihood of recurrence is any higher in children with tachycardia if you stop it, say, at 8 months versus 12 months. So if that's the case, maybe there would be some benefit to just getting off of meds as early as possible. So what I normally do, which is, entirely not based on science, is I will adjust medication doses until a child is 6 months. And then at 6 months, I start to allow the children to outgrow their dose so that by the time they reach a year of age, they're effectively almost on a, for lack of a better term, a homeopathic dose of antiarrhythmic therapy. So I'll feel a little more comfortable stopping it. But perhaps I'm being too conservative and I probably could have stopped it a lot earlier. Okay, very good. Everybody did well today. I think with that, we'll stop and hope everybody has a great day. I will see you at Sinai in just a few minutes. Take care, everyone.
Thank you.
Thank you.